This presentation will cover the current status and concerns of radiation doses in radiology, as well as the future prospects and developments in progress. We will begin by briefly familiarising ourselves with the basics by which ionising radiation is derived, calculated and delivered to a patient as a dose in order to acquire the generation of a clinical image. Radiation is a form of energy transmitted through the air as an electromagnetic wave. In addition to its universal occurrence in the environment, radiation also comes from man-made sources such as medical and industrial activities. The radiation relevant to clinical applications in radiology is known as ionising radiation, consisting of electromagnetic waves with sufficient energy to cause electrons to become detached from atoms and molecules in the matter they pass through, changing their structure, a process known as ionisation. A quantifiable dose of ionising radiation allows the physician to derive an image of a particular patient's anatomy for diagnostic or interventional purposes, further adding to a patient's natural background radiation. The term exposure refers to the concentration in air of radiation at a specific point and is the ionisation produced in a specific volume of air. We all have an intuitive understanding of what dose is, but a radiation dose reflecting potential damage to organic tissue cannot be simply defined as a certain amount of radiation energy per kilogram of body surface. That is why it's important to understand the three differential dose types. Absorbed dose is a measure of the energy deposited in a medium by ionising radiation. It carries the unit joule per kilogram or simply 1 gray, denoted GY. This rather simple definition is a physical quantity and does not reflect the biological effects of radiation, since it does not take into account the type of radiation or the damage it may cause towards different tissues. The equivalent dose is a measure of the biological damage to living tissue as a result of radiation exposure. The dose equivalent is calculated as the product of absorbed dose in tissue multiplied by a factor that weighs the damage caused to biological tissue. This factor represents a particular type of radiation, as illustrated in the table. In the case of X-rays used in CT, the weighting factor is 1. Therefore, the equivalent dose is the same as the absorbed dose. The dose equivalent is expressed in sieverts. Radiation dose isn't received uniformly over the entire body, as different organs and tissue respond to radiation differently. To account for this, organs and tissues have been assigned a tissue weighting factor based on their radiation risk. When the equivalent dose is multiplied by the tissue weighting factor, we get effective dose. Effective dose is expressed in sieverts and is a single dose parameter that reflects the risk of non-uniform exposure in terms of whole body exposure. Irradiation only becomes problematic beyond a given threshold in a short period of time, in which deterministic damage will occur. This term implies that radiation poisoning definitely occurs and that the damage is dependent on the amount of radiation received. Deterministic radiation involves the killing of somatic cells, potentially resulting in changes in blood count, hair loss, tissue necrosis, or cataracts. Even low X-ray doses may cause long-term damage such as leukemia and solid tumour formation. Such cases arise when the effect is not cell death, but instead a modification of the cell's biological properties without impairing their capacity to reproduce. There is no threshold dose for stochastic damage. In contrast to deterministic damage, the probability and not the severity of biological damage increase with dose. The onset of disease such as leukemia and tumour formation caused by stochastic damage develops only after a latency period of several years or decades. The Royal Australian and New Zealand College of Radiologists estimate that a single CT scan raises one's chance of developing cancer over one's lifetime by 0.04%. So if someone has a 30% lifetime chance of developing cancer, this rises to 30.04% after a single CT scan. The United Nations Scientific Committee on the Effects of Atomic Radiation reported that an increase in the risk of tumour induction proportionate to the radiation dose is consistent with developing knowledge. Furthermore, the linear non-threshold model remains accordingly the most scientifically defensible approximation of low-dose response. However, a strictly linear dose response should not be expected in all circumstances. Given the substantial benefits of medical imaging, the end goal is to enable the radiologist to acquire the most diagnostically acceptable image with a dose as low as reasonably achievable. Harnessing the use of ionizing radiation in its clinical applications allows detection of hidden diseases to derive accurate diagnoses, as well as predicting future pathophysiological events. It must also be understood that reducing the dose of radiation has an adverse effect on image quality and heightening image noise. Therefore, in the absence of risk of the patient, much higher doses would frequently be used. The underlying concern is evaluating the clinical benefit over the radiation-induced risk. Primary care physicians require basic understanding of these risks because it is the patient that generally expresses concerns over radiation risk. The advantage of utilizing ionizing radiation is that it provides favorable medical results and in some cases avoids the need for conventional surgery. Although the risk of developing cancer through most examinations is slightly elevated, as it is in addition to the 2.4 millisieverts of natural background radiation per year, the amount of radiation used is still very small and the benefits greatly outweigh the risk of harm. The UK Health Protection Agency calculated that an X-ray of your chest, teeth, arms or feet is the equivalent to a few days' worth of background radiation and has a less than 1 million chance of causing cancer. However, advances in radiologic technology continues to develop rapidly, propelled by the benefits of shorter scan times and increased matrix sizes with the potential to provide functional information. Shorter scan times result in a higher patient throughput, hence less wait between patients and more convenient in terms of patients' clinical management. While the dose to the individual and the consequent risk is relatively low, the increasing image and therapeutic applications across the population is becoming an increasing public health concern due to the escalating risk of the expression of stochastic effects. Dr. Richard Smart, a former expert in the field of radiation protection, will be providing us with some insight on the current concerns regarding patient safety in Australia.
Okay, there's two concerns that come to mind. Firstly is the inability to track patients' doses across their lifespan, particularly as many people have studies both in the private sector and in the public sector, and often the information from one doesn't get passed through to the other. The other issue is inappropriate ordering of tests when there may be another test that's more appropriate for that patient, or even the situation where you've got a patient who has a study by mistake where due to human error the wrong request is issued, particularly in the emergency departments of busy hospitals.
Dr. Smart's concern of Australia's inability to track patient doses across their lifetime could be eliminated through characteristics of Sweden's healthcare system, as they have managed to implement lifetime histories of diagnostic X-ray examinations based on patients' medical records. Their capability of providing this data stems from the strong financial incentive for people to visit designated hospitals that are part of the public healthcare system, hence enabling access to a patient's history of radiation exposure from various X-ray procedures. 95% of all medical diagnostic X-ray examinations in Sweden reportedly were performed at facilities that were part of the public healthcare system that harbour an archive from radiation dose history from birth. Radiation safety experts from the United Nations International Atomic Agency have raised concerns over efforts required to ensure better protection of patients from unnecessary exposure. The agency implemented the concept of a smart card in 2013, with the major purpose of tracking patient exposure history. The scope of patient radiation exposure tracking is to cover all imaging modalities which use ionizing radiation for interventional procedures. The scope also includes radiation dose recording, reporting, and tracking. The major goals of tracking include supporting accountability for patient safety, strengthening the process of justification at a point of care for the referring practitioner, and supporting optimization and diagnostic reference levels. The Australian Radiation Protection and Nuclear Safety Agency utilises diagnostic reference levels, or DRLs, with the objective of avoiding excessive radiation dose to patients that does not contribute to additional diagnostic information. The diagnostic reference level is based on regional and national dose levels that are not expected to be exceeded for standard procedures. Each dose level submitted is used to calculate the median dose delivered to a standard patient for a given protocol. The DRL was then based on the 75th percentile of the resulting reference level distribution. The 25% above this value need to review their techniques with the objective of meeting standard national DRL or lower. Importantly, a DRL is not a regulatory limit on the dose that can be administered to a patient, it is simply an indicative value. If the dose delivered by an imaging facility consistently exceeds the DRL, it is an indication that the facility should further optimize their scanning protocols. The central message for this presentation can be divided into three important ideas. Firstly, that advances in radiologic technology has enabled radiologists to derive diagnostically acceptable images, whilst minimising the dose to as low as reasonably achievable. While understanding the consequences of long-term stochastic effects due to unnecessary radiation exposure, most likely a result of ineffective patient dose tracking, and as Dr. Richard Smart put it, inappropriate ordering of tests when there may be another test that's more appropriate for the patient. And last of all, the effective implementation of diagnostic reference levels that are allowing improvements to local, regional, or national distributions of observed doses, hence reducing the frequency of unjustified high or low dose values. This in turn will promote future optimum ranges for doses for specified medical imaging protocols.